Good afternoon, students. Today we have first lecture on respiratory system, and today we will be discussing such subtopics, which are main steps of respiration and their physiological features, structural components of the respiratory system and their role in the breathing, non-respiratory functions of the lungs, biomechanics of the respiratory act, inhalation and exhalation mechanism, factors that affect lung ventilation, lung compliance and its role in breathing, and physiological role of surfactants, oxygen cost of breathing, and types of ventilation disorders. Also, we will be discussing spirography and its diagnostic value, and gas exchange between alveolar and atmospheric air at the level of the transient zone of lungs. So first subtopic which we will be discussing today is steps of respiration. So there are 5 steps of respiration. First, second, third, and fourth steps are usually called as external breathing, and the last 5th step you will be discuss with your teachers in biochemistry subject. So the first step is called ventilation of the lungs. It's a transport of respiratory gases from external environment into alveoli and in reverse direction, and the gas exchange between airways and alveoli in transitory zone of bronchial tree. Second step is the exchange of respiratory gases between alveoli and blood. Third step is transport of respiratory gases by blood, and next step is exchange of respiratory gases between blood and tissues, and the last step is called internal respiration or tissue respiration. It is the process of biological oxidation of organic substrates that happens in these mitochondria. So respiratory system, as you see on this picture, respiratory system is not the only one system that ensure all these steps. So it is impossible to perform all these steps without cardiovascular system, as well as the nervous and endocrine systems which regulate all these processes. So 2 fundamental mechanisms that perform all these steps are diffusion and convection. So they are responsible for transport of gases at different steps of respiration process. So the convection happens because of pressure gradient. It requires a lot of energy and provides transport of gases on large distances. This kind of gas transport is typical for the first and third steps of respiration. The diffusion is performed due to the gradient, partial pressure gradients of gas mixture components of gases and dissolved fluids, the gases dissolved in fluids, and this type of mechanisms do not require energy, and besides, respiratory gases are transporting in such way only on short distances compared to convection, which helps to transport gases to a long distances. So diffusion takes place on the first, second, and fourth steps of respiration. So now let's discuss main respiratory structures. So all respiratory structures can be divided into three main groups. So first is airways or respiratory tracts. Tract is a conductive system that carries out air from the external environment to the exchange surface and in opposite direction. Second is alveoli. One second. Second is alveoli, which are spherical sacs, which terminate in branching of respiratory bronchioles. Alveoli are supplied with a net of capillaries that belong to a long circle of hemodynamics and form an exchange surface for two-way diffusion of respiratory gases. And the third one is bone structure and skeletal muscles of the chest and abdomen, which provide ventilation of the alveoli. So it is there is another classification of respiratory tract, which classify all respiratory structures into upper and lower respiratory tracts. So nasal cavity, mouth cavity, throat, and larynx belong to the upper respiratory tract. Main functions of the upper respiratory tract is heating or cooling the inhaled air, humidifying this air, and purifying. Also, upper respiratory tract is responsible for olfaction. So olfactory epithelium, which is present in the nasal cavity, is the peripheral part of the olfactory analyzer. And also it takes part in the sound producing because of vocal cords, which are located in the larynx. Lower respiratory tract is represented by the trachea and bronchial tree of the lungs and consists of 23 generations of bronchial tubes. So let's discuss about these 23 generations, because it's important to know the differences about the structure of each generation of bronchial tree. So as you see on this picture, trachea is considered to be 0 generation. Right and left bronchi is 1st generation, and the branching considered to be 2nd generation, and so on and so on. So the first 16 generations, I don't know, do you see my mouse or not? I hope you see it. So first 16 generation of bronchial tree, making up the conductive zone of the bronchial tree, since the main function of this generation is to conduct air to following zone. Next one, 17, 18, and 19th generation form transitory zone, in which diffusion, mixing of fresh inhaled and alveolar air occurs. This zone contains the single alveoli stepping aside from the respiratory bronchioles. That's why the gas exchange with blood of pulmonary capillaries occurs to some extent even in this zone. The last 4 generations, from 20 to 23, are called respiratory zone. And this zone, these generations are main generation which is responsible for gas exchange with blood and alveoli. So this zone is formed by alveolar ducts and alveolar sacs. And it is interesting to mention that the air composition in this zone is relatively constant and doesn't depend on breathing phases. The other important thing that first 10 generations of bronchial tree have concentric cartilage. You see this on this picture. So this cartilage prevent bronchioles collapsing. Starting from 11 generation, all these airways are free from cartilaginous ring and are called bronchioles. And only negative pressure in pleural cavity prevents the collapsing during expiration. So alveoli are being represented or appeared in these next generations as single branching of respiratory bronchioles. So starting from 20 generation, 20, 21, and 22 generation, they are completely consist of alveoli, forming the alveolar ducts. And only 23 generations is represented by the alveolar sacs. So what is it, pulmonary blood shunting? Let's discuss it. So lungs are supplied with blood from two sources, pulmonary artery and bronchial artery. The alveoli obtain venous blood from pulmonary artery and provide its oxygenation. The bronchial tree obtains arterial blood from bronchial arteries, and then this blood is converted into venous one, supplying the bronchial walls with oxygen. This venous blood is mixing with arterial blood flowing from the alveoli into the pulmonary veins, and to some extent reduces oxygenation of mixed blood that has been entering into the left atrium. And this feature of mixing blood and reducing its oxygenation is called pulmonary blood shunting. Non-respiratory functions of the lungs. So except for respiration and conducting of air and gas exchange between alveoli and tissue, lungs perform other functions which are called non-respiratory functions. So these are participation in the compensation of hemodynamic disorders or disturbances. It is realized due to ability of vascular pulmonary bed to deposit a significant amount of blood without essential disturbances of the respiratory function. So lungs can deposit up to 500 milliliters of blood. Next one is metabolic function. So the lungs are the place where many physiologically active substances are synthesized and metabolized. So for instance, conversion of angiotensin 1 into angiotensin 2 happening occurs in the lungs, biosynthesis of prostaglandins, leukotrienes, kinins, and other biologically active substances. Next one is excretory function. A lot of toxic products of metabolism are excreting through lungs during breathing, such as ammonia at the kidneys pathology, acetone in the case of diabetes mellitus, and alcohols, steam are excreting by the help of the lungs. Next one is participation in the thermoregulation. So in case of hyperventilation of the lungs, the great amount of heat can be expelled out through the lungs by exhaling the heated and humidifying air. On the other hand, it can be delayed in the body during hypoventilation. So by changing the rate of breathing, we can regulate to some extent our temperature. So next one, participation in the maintenance of acid-base equilibrium or acid-base balance is realized through ventilatively opened bicarbonate buffer system. Next one, protective function. Blood contacts with a great amount of lymphoid structures localized in the bronchial walls, and alveoli contain large quantity of macrophages. All these factors protect the body from carriers of foreign genetic information, such as microorganisms or own genetically defective cells. Next one is blood filtration and removing of microemboli from the blood. It means that the venous blood has been purifying from microemboli while it passes through pulmonary vessels by means of the filtration into alveoli and the following excretion of sputum. This prevents microemboli from entering the systemic hemodynamics. And also, as we have been discussed before, respiratory system takes part in the olfactory sensation and sound producing. So now let's discuss about mechanism of breathing. So there are two types of movements distinguished in the respiratory processes, which are called inhalation and exhalation, or inspiration and expiration. And together they constitute to one respiratory cycle. So the crucial role in the mechanism of inspiration play the primary inspiratory muscles. So on the left, you see muscles that are involved in inspiration or inhalation process. The mains are diaphragm and external intercostal muscles. But in case of force inspiration, some other muscles can be involved in this process, and these muscles are called accessory inspiratory muscles, which are sternocleidomastoideus and scalene group. In case of expiration, this process is passive and doesn't need participation of skeletal muscles during calm breathing, because it is performed by the help of elastic force of the lungs. But in case of the force exhalation, accessory expiratory muscles are involved, which are internal intercostal muscles, transversus thoracic muscle, external oblique muscle, internal oblique muscle, rectus abdominis muscle, which helps to perform forceful exhalation. In order to understand the biomechanism of respiration, it is necessary to first consider different pressures in different areas of respiratory system. So first one important pressure is called atmospheric pressure, which is equal to 760 millimeters mercury. Next one is intraplural pressure, which is the air pressure inside alveoli. And it has been fluctuating during breathing cycle, plus minus 1 millimeter mercury. So it is equal to 759 millimeters mercury approximately. Next one is intrapleural pressure, which is lower into 3-5 millimeters mercury, then atmospheric pressure and equal to 756 millimeters mercury. And the next one is transpulmonary pressure, which is the difference between air pressure inside alveoli and intrapleural pressure. So now let's discuss about the exact mechanism of breathing. So the pressure and volume are related in an opposite way, which is called as Boyle's law. So for example, we can use the syringe to explain this law. So pulling back on the plunger of a syringe increases the volume inside the barrel, but lower the air pressure inside the barrel. Atmospheric pressure then pushes outside air into the syringe. The opposite occurs in case pushing on the plunger of a syringe, which reduces the volume inside the syringe, but the pressure inside increases, which leads to forcing air out into the atmosphere. So the movement of air inside and outside of the lungs occurs in much the same way. So when when the respiratory muscles are at the rest state, the pressure on the inside of the lungs and alveoli and on the outside of thoracic wall are about the same. If the pressure inside the lungs and alveoli decreases, outside air will then be pushed into the airways by atmospheric pressure. This is what happens during normal inspiration. So once again, what are the sequence of events in case of inspiration? So first step, inspiratory muscles contract, which means the diaphragm descends and rib cage rises. Second, thoracic cavity volume increases, lungs stretched, intrapulmonary volume increases. Next one, intrapulmonary pressure drops to minus approximately 1 millimeters mercury, and air flows into lungs down its pressure gradient until intrapulmonary pressure is 0, which means equal to atmospheric pressure. All this process is active and requires ATP for muscle contraction. What happens during expiration? So an expiration, calm expiration, is a passive process because it does not require the participation of breathing muscles. The stopping of inspiratory muscles contraction leads to domination of pulmonary elastic forces, which decrease alveoli pressure, which in turn causes the transmural pressure to decrease and leads to pulmonary deflation. Alveolar pressure becomes higher to 1 to millimeters mercury, then atmospheric pressure, and due to this pressure gradient, the air moves towards the upper respiratory tract. In case of forceful expiration, as I said previously, accessory inspiratory muscles are being involved, and in this case, all the pressure gradients can increase in 2-3 times more. So once again, let's repeat what are the sequence of events in case of expiration. Due to recoil of costal cartilage, thoracic cavity volume decreases, elastic lungs recoil passively, intrapulmonary volume decreases, and intrapulmonary pressure rises to 1 millimeter mercury. Air flows out of lungs down its pressure gradient until intrapulmonary pressure is 0. So even in the absence of the respiratory movements, the lungs are usually expanded and contain some air, staying under the pressure that is equal to atmospheric one. The cause of this is negative pressure in pleural cavity, which is called intrapleural pressure, which is created by two opposite forces applied to parietal and visceral pleural leaves. A parietal leaf is closely fused with internal chest wall and undergoes the influence of elastic force of chest skeleton directed outside. So the given force is trying to increase the chest volume. An internal leaf is closely fused with pulmonary surface and undergoes the action of elastic force of lungs, trying to decrease the volumes because it is directed inside the chest. Besides, both pleural leaves are firmly connected from within by the forces of molecular interaction of water polar molecules, forming thin layer of intrapleural liquid. But this liquid allows both sleeves to glide in relation to each other freely. Its volume fluctuates between 4-12 milliliters in lungs of healthy person. However, in case of pathology, in case, for example, of pleuritis, which means inflammation of pleural leaves, the volume and composition of this liquid might be essentially changed, which result in disorders of pulmonary ventilation. Now let's discuss about such important disorder, which is called pneumothorax, which is collapse of lungs. So complete hermeticity of pleural cavity is the necessary condition for existing the negative pleural pressure, which we were discussing on previous slide. If this hermeticity is broken, a pneumothorax arises. This is the state at which atmospheric air is penetrating into pleural cavity, as seen as the right picture. So as a result, negative pleural pressure disappears and the lung has been collapsing at the affected site. Such pulmonary collapse has been called by the term atelectasis, and it makes lung ventilation impossible. Now let's discuss factors that affect ventilation of the lungs. So the pulmonary compliance and the airway resistance are two the most important factors that affect pulmonary ventilation. So let's discuss first, which is compliance. So pulmonary compliance is the term that refers to the change of lung volume due to the transmural pressure change. If pulmonary compliance is marked as CL, pulmonary volume change will be marked as VL, difference in volumes, and transpolar pressure will be marked as difference in transpolar pressures. So the average value of this pulmonary compliance is about 0.2 liter per centimeter of for the lungs of healthy human. In the case of compliance decrease, a patient must spend too much energy used on the inspiratory muscle contraction in order to to ensure pulmonary extension during inspiration. As a rule, in this case, breathing becomes superficial and frequent. In particular, pulmonary compliance is determined by two factors. First one is elasticity of the lung tissues, and second is surface tension of the fluid lining alveoli. The elasticity of the lung tissue depends on the ratio between elastic and collagen fibers, and the second, surface tension of the fluid lining alveoli, depends on the production of the surfactant, and the function of the surfactant we will discuss a bit later today on the lecture. So the second factor affecting ventilation of the lungs is airway resistance. So the bronchial radius has the greatest influence on all the factors affecting the air resistance, because as you see from this equation, the length of the bronchi remains constant and air viscosity is changing insignificantly in normal state, but in some cases, for example, in case of increased humidity of the air, its influence of viscosity becoming noticeable, and it is hard to breathe because of increased air resistance. So it is necessary to note that under the radius in this equation, you should understand total radius of certain bronchial generation. That's why trachea and cartilages elements of bronchial tree, which means first and 10 generations, whose total cross-section square is the smallest, form nearly 90% of the total air resistance. The cartilaginous elements in walls of these bronchi prevent the sharp changes of their radius. Nevertheless, their resistance has been essentially increasing during intense mucus secretion of bronchial epithelium and makes pulmonary ventilation difficult. Concerning bronchioles of the next bronchial generation, they are forming very small air resistance due to huge total cross-section square. But since they are completely free from cartilage, the radius may be changed under the influence of autonomic nervous system hormones, some hormones, and the paracrine biologically active substances. So the bronchi are supplied with powerful parasympathetic innervation and relatively smaller sympathetic one. So parasympathetic part of the autonomic nervous system produced and expressed bronchoconstrictions, bronchoconstrictor effect through the M cholinergic receptors, and sympathetic part of the autonomic nervous system provides bronchodilation through the beta-2 receptors, and also adrenaline and hypercapnia also leads to bronchodilation. Now let's back to the main function of the surfactant. So what is it, surfactant? Surfactant is the biological active substance of the lipid nature, which decreases surface tension force of liquid layer in more than 10 times, and therefore prevents rapid pulmonary collapse. Especially it is important during the expiration that creates the tendency to lung deflation by itself. The deep breathing contributes to the surfactant secretion by the alveolocytes, second type, when alveoli are being stretched by fresh air. In the condition of hypoxia, when some toxic substances, for example, CO, it affects pulmonary tissues, or in the course of severe long-lasting delivery of newborn, this secretion is being slowed down. So in the second case, the newborn child even unable to inhale by itself for the first time after being born. So such state of newborn is called respiratory distress syndrome of the newborn, and is being treated by synthetic surfactant injection in bronchial tubes. So now let's talk about the types of respiratory muscle work. So from the point of energy view, the pulmonary ventilation in healthy people is rather low-cost process. Only primary inspiratory muscles have been functioning during calm breathing. So their energy is being spent on work which can be divided in three types. So first one is elastic work. It's a work against the forces of elastic recoil of the lungs when inhaled. Second is tissue resistive work against the forces of viscosity of the lungs and structures of the chest. And the third one is frictional work against the forces of air resistance in the bronchi. What is it? Oxygen cost of breathing. It is the percentage of oxygen consumption per 1 minute, which is spent by all types of respiratory muscle work, and its normal range from 3 to 5%. And it is accepted to divide the typical ventilation disorders into two types: restrictive disorders and obstructive disorders. So the elastic work of inspiratory muscles has been abnormally increased during restrictive disorders. Patients' breathing becoming superficial and frequent. Accessory inspiratory muscles are being involved in this respiratory cycle, in this type of disorders. Such diseases as pulmonary fibrosis, silicosis, respiratory distress syndrome of newborns are the examples of restrictive disorders. In the case of obstructive disorders, the frictional work third type of works, has been increasing, what result in the involving of accessory inspiratory and expiratory muscles into breathing. The expiration is especially complicated. Expiration, not inhalation. That is why a person breathes deeply but relatively slowly, as far as such a ventilation regime is energy cost profitable for him. The example of obstructive disorders are bronchial asthma, emphysema, and chronic obstructive bronchitis. And now let's move to the next subtopic of today's lecture, which is spirography. So this is the graphic record of inspired and expired air volumes during breathing. So you can obtain quantitative characteristic of pulmonary ventilation by the means of spirography and conduct functional lung tests, allowing to establish mechanism and localization of ventilation disorders. So the quantitative values and values of lung volumes and lung capacities can be obtained by the help of spirography. So what are the lung volumes that you can get by performing spirography to the patient? These are tidal volume, which is volume of air inspired and expired during a normal inspiration or expiration, and it is equal to 500 milliliters. Inspiratory reserve volume, this is the amount of air inspired forcefully after inspiration of normal tidal volume. It is equal to 2,500 milliliters. Expiratory reserve volume, amount of air forcefully expired after expiration of normal tidal volume, equal to 1 liter. Residual volume, volume of air remaining in the respiratory passages and lungs after the most forceful expiration, and it is equal to 1 liter. These were lung volumes. Now let's talk about lung capacities. Lung capacities, what is the difference between lung capacities and lung volumes? So lung volumes, it is a simple index which is being received from record, while lung capacities, it is a calculated index. So it's a sum, algebraic sum of several volumes. So for example, inspiratory capacity, it is the tidal volume plus inspiratory reserve volume, equal to 3,000 milliliters. Functional residual capacity, it is expiratory reserve volume plus residual volume. Vital capacity, it is inspiratory reserve volume plus tidal volume plus expiratory reserve volume. And total lung capacity, it is inspiratory reserve volume plus expiratory reserve volume plus tidal volume and plus residual volume, equals to 5,000 milliliters. So this is the graph of lung volumes and capacities that is get by spirography, and normal levels of each of these volumes and capacities. So what are the dead space of pulmonary lungs? So there are 3 types of dead spaces: anatomic, alveolar, and physiologic. Anatomic dead space, it is a space which occurs, which is present in the conducting airways, estimated to be about 1 milliliter per pound of ideal body weight. Second is alveolar dead space, which is normal lung volume that has become unable to take part in gas exchange because of reduction in pulmonary blood volume. And the third one is physiologic dead space. It is a combination of anatomic and alveolar dead spaces. So what are the pulmonary function tests which you can get by the help of spirography? So total minute ventilation or minute respiratory volume. It is the air volume inhaled into lungs per 1 minute. Its value ranges within 6 to 8 liters per minute during calm breathing. And it may be increased up to 30-40 liters per minute during the maximum possible inhalation. Second one is forced expiratory volume in 1 second, or FEV1, is an expressed percentage part of lung vital capacity, which can be exhaled after maximal inspiration during maximal forced expiration per the first second. This index allows to conduct the differential diagnostics between restrictive and obstructive ventilation disorder. Those people with obstructive lung disease typically have this parameter less than 80% of the vital capacity, because it is difficult for them to expire or exhale air rapidly through the narrowed airways. Restrictive lung disease, in contrast, are characterized by a reduced vital capacity, but normal FEV1. Next one is alveolar ventilation, is the total volume of fresh air entering the alveoli per 1 minute. Alveolar ventilation rate is being calculated by tidal volume minus anatomical dead space and multiply into respiratory rate. So the normal amount of alveolar ventilation is approximately 4,200 milliliters per minute. So once again, in case of restrictive disorders, vital capacity will be reduced, and it means that less air in lungs is present. And in case of obstructive disorders, rate of expiration is reduced. So in other words, lungs are fine, but bronchi are obstructed. So here you have two spirographies of two different persons. So on the left graph, you see the spirography of a person with obstructive lung disease, and on the right graph, you see spirogram of a person with restrictive lung disease. So what is the differential diagnosis of these two types of disorders? Because of a patient with obstructive lung disease has more difficulty emptying the lungs than filling them, the total lung capacity is essentially normal, but the functional residual capacity and the residual volume are elevated due to additional air trapped in the lungs following expiration. Another common finding is a markedly reduced forced expiration, first expiratory volume in 1 second, or phi-EV1, because the airflow rate is reduced by the airway obstruction. And in case of restrictive lung disease, the lungs are less compliant than normal, so total lung capacity and inspiratory capacity and vital capacity are reduced because the lungs cannot be expanded as normal. So once again, obstructive disorders characterized by limitation of expiratory airflow, so that airways cannot empty as rapidly compared to normal, such as through narrowed airways from bronchospasm or inflammation. And examples are bronchial asthma, emphysema, and cystic fibrosis. And restrictive disorders characterized by reduced lung volumes and reduced lung compliance. Examples are interstitial fibrosis, scoliosis, obesity, lung resection, neuromuscular diseases, and cystic fibrosis as well. And now last subtopic for today's lecture is gas exchange between alveolar air and atmospheric air in the transient zone of the lungs. So gas exchange in this zone is realized due to both convection and diffusion. So since the total cross-section square of the bronchial tree has been increasing with increase of its bronchial level, the linear speed of airflow is dropping respectively. The calculations shows that the first air portion have been reaching the 17th generations bronchial generations for 0.9 seconds. From 20 bronchial generations for 2.1 seconds, and the 23rd bronchial generation only for 6.7 seconds during calm breathing. However, the typical inspiration lasts only 1.5 to 2 seconds. This means that if air entered the alveoli only by convection, then the lungs would not be ventilated. Then why the fresh air is transported into the alveoli? The answer that explains this is that the diffusion of respiratory gases continues gas transport beginning from the 70th bronchial generation. The transport by convection has been continuing to the 19th bronchial generations during forced breathing. Therefore, transitory part of bronchial tree, which is from 17th to 19th generations, is special buffer zone between atmospheric and alveolar air. Its upper part is being exchanged by oxygen and carbon dioxide with inhaled air, and lower part is exchanging with alveolar air. That's why the alveolar air composition is relatively stable and doesn't depend on the respiratory phases in case of inspiration and expiration. So if you look at the table on this slide, you will see concentration of different gases in the atmospheric, which is inhaled air, exhaled air, and alveolar air. And according to this table, it can be concluded that the concentration gradient of oxygen and carbon dioxide exists between inhaled or atmospheric air and exhaled air. So you can see that concentration oxygen of atmospheric air is almost 21%, while concentration of oxygen in exhaled air is only 16. So this exact gradient is the driving force of diffusion gas exchange in transitory zone of lungs. And this gradient is existing for all other gases, concentration present in each of these type of air. So this is all for today's lecture. Next week, we will be discussing next steps of the respiratory processes and the mechanisms of the regulation. Thank you for your attention. Bye-bye.